We next call upon Dr. Leela Vyas.
Giving me this opportunity. Topic given me is that decompensated heart disease in pregnancy. Once you open all, the PGs are here. The William writes, we haven't seen these cases since long after 2000 they are saying. But in our scenario, we day to day coming across all these patients. So, this cardiac disease complicates around 2% of all pregnancies in India, 0.2 to 4%, and this is the 1/5 of all the maternal mortality in India. And 40% of the patient, we all know these lesions can be diagnosed during only pregnancy. And I have experience, I was making this presentation. Last week, the 3 patients we diagnosed. In antenatal, same day the 3 patients came, took history and then gone from the Iccob and all, then came out of the one of the MS. And 3 days back, one patient of Eisenmenger syndrome, she died during cesarean, after cesarean. So, this is the scenario still in our country. So, it is so important for us to deal these patients in a proper way. So, what is decompensated heart disease? So, NYHA classification 3rd and 4th, we take it as a moderate risk, which is 5 to 15% mortality. Class 1 and 2, they have the better pregnancy output. The women may apparently healthy at the beginning of the pregnancy, but may deteriorate and may turn into the class 4 changes. So, that is why these patients are require a close supervision with us. These classification, this functional class 3 and 4, the pulmonary edema, which is the most common adverse cardiac event which we used to find, and then the mortality increase in these cases. So, WHO says that class 3 and 4 of NYHA is the class 4 WHO classification, they classified like that. So, various conditions are there. Once you diagnose these cardiac disease, the pregnancy is contraindicated, but still in our society they are not accepting, even we are counseling, they never go with that. The pulmonary hypertension of any cause, primary Eisenmenger syndrome, previous peripartum cardiomyopathy with any residual impairment of the left ventricular function, Marfan syndrome with aortic root dilatation, aortic dilatations, and these conditions nowadays it is diagnosed, but still the patients are coming with the diagnosis because of the social trauma and all, they are not disclosing in their society and they got married and going with this. So, various this risk for the maternal mortality, we give you the minimal is with the ASD, VSD, PDA or pulmonary or tricuspid disease, Fallot's tetralogy, if it is corrected then it comes under the minimal risk. Then moderate, these are the NYHA 3 and 4, as Fallot's tetralogy if it is uncorrected, Marfan syndrome, previous MI, aortic contractions, these have mortality risk of 5 to 15%, but major risk is in the pulmonary hypertension, aortic coarctation, and these have that 25 to 30% of mortality risk is there. These risk factors, adverse maternal cardiac events, the most common which is very dangerous is the pulmonary edema, and definitely one is the arrhythmias, and the systemic ventricular ejection fraction less than 40%, it comes a general risk factor. So, that is why we always say that echo is important during the antenatal period. Then again the mitral valve diseases are there, their measurements are required. Cardiac events, arrhythmias, pulmonary edema, stroke, if any history of these in the previous prior to the pregnancy, these are again of the high risk factors. So, these general risk factors according to, if it is 0 risk factor less than 5% risk, 1 factor 27, if more than 2 or more than 2, then it comes around 75% risk. But the pregnancy itself has some physiological changes, and these changes resembles with any of the cardiac problems. We normally see the mild jugular venous distension is there, lower extremity edema which is very common, then this deviation of maximal impulse on the chest, volume load, and flow murmurs you used to see in our patients, wide pulse pressure and increased heart rates are there. We all know cardiac output increases 15% in early labor, 25% in first stage, 50% during expulsive efforts and 80% during early postpartum due to autotransfusion. And that is why according to these, because it is of the physiological changes, of lady comes with a cardiac disease, then we decide what should be the route of delivery in these patients. And some of the clinical indicators in all are having these BSOG outdoors, especially in the medical college you have antenatal patient load of 100 or 200 patients, but still we have to see their symptoms that progressive dyspnea or orthopnea is there, nocturnal cough, hemoptysis, syncope, chest pain. If they are complaining of that, then our house surgeon should know that these to be shown to the seniors. And clinical findings, cyanosis, clubbing, these are very rarely nowadays we see because of the most of the RSDs, these are treated one. And still on examination that once every time that stent should be put on the chest in all pregnant ladies in every visit. It should not be only in the first trimester, and usually in the what happens in the once you diagnose the pregnancy, nowadays even we are not doing the PV just for the urine pregnancy test or the sonography, but still the clinical examination is very important. It's every antenatal visit you put your stent on the chest and see for that. So many patients, they are even not disclosing the asthma. These are the social problems with us. So we should put our stethoscope on their chest. So these are the various signs of the left ventricular failure. You know the pulmonary artery congestion will be there. Patient comes with the orthopnea, they give history, easy fatigability, shortness of breath. You can diagnose in your long queue they are standing. If lady is just having breathlessness, you just always call these patients in front and see first, and they should not wait. Then right heart failure, whatever, we all know weight gain, again with the pregnancy it is there, dependent edema, we all know this occurs in the pregnancy, but excessively then definitely we go with that. Hepatomegaly and increase these jugular pressure, these are the important signs we should look for that. So normal pregnancy, again the shortness of the breath, but in the left ventricular failure, the patient limits her activity. If we ask them history that she is not able to walk that, even on the standing on the queue for her examination, she used to say, doctor मेरे को नहीं देखा खड़ा नहीं हुआ जा रहा है, मुझे बैठ जाने दीजिए, मुझे पहले देखने दीजिए. These are the normally we see in our routine outdoor. And one is the cough and the night cough. They say, I have taken so many medicine, all cough syrups they are taking, and they are not relieved. Definitely, these patients are to be taken care and see for these heart disease. So preconceptional counseling, which is very important, but it is very rarely done. Rather that the females, they are not coming for the preconception. But it is all like that we are doing pap smear, it is an opportunistic test. These are the all things, the young girls coming for the various problems, because the young girls nowadays the PCO you see that the 28, 27 years, that yet they are not married. You take history, that's why now we are promoting that NCDs, non-communicable disease should be taken care by the gynecologist. The lady can come for their white discharge, but they will not go. If you check a BP, it is 180 by 100. But they'll say, nahi doctor, मेरे को तो ऐसा ही सब ठीक चलता है, they are not taking care. But we have to insist, it becomes our responsibility to go there. So like that, all the young girls, those who are coming, we do the preconceptional counseling that and take a thorough history, so many things we can take out by that. Examination, functional classification, if nowadays the more of the cardiologists are available in every city. So the young cardiologists, they are sending these girls to the gynecologists that you just take and counsel them. So we should counsel regarding these complications according to their disease. Then risk classification should be done beforehand. Need for the early hospital admission, these patients, we should explain that. And this, again, the termination of the pregnancy offered in the specific conditions. Even they have been previously advised that they should not get pregnant, but still because of some pressure they have become pregnant and the condition deteriorate, we should offer them these terminations. So this is our teamwork. We need cardiologist help. Obstetrician definitely is the whole and soul for that. Sometimes we need anesthesiologist and neonatologist are required to us. So in each antenatal visit, these NYHA classification in each visit to be repeated, easy fatigability and all these general complaints we should see in all the antenatal visits. Then chest radiogram you can require, echocardiography is required, and these that's why we say initially we see and then it is at the 28 to 30 weeks we are repeating this, and the fetal echocardiography, that is these are to be seen. And nowadays with the all expertization of the fetal medicine person, they are able to diagnose these cardiac problems up to the 20 weeks. So it becomes for us that major lesions there we can explain to them, because there is a chances of transmission of congenital heart disease can be transmitted into, means the baby may have these chances increases. So our antepartum antenatal management, that diet, rest and fresh air, that we iron, calcium, they should not become anemic. If anemic, then it should be corrected earlier. Then dietary salt restriction, definitely here, this is the only one condition. Even in the hypertension, we just avoid that the extra salt they should not take, but here we have to do, because 4 to 6 gram per day, that prevents the excessive retention of salt and water in these ladies. So, the frequent and regular visits should be there. Class 1 and 2 patients need to be seen once in a month, and more severe cases should be seen weekly, and cases of the 3 and 4, they should be admitted as soon as they diagnose. So, these cardiological references we need in the first and definitely in the 28, 30, these are the minimum, but as and when required we need their help. We avoid any infection definitely, so they should not land, because these are the patient once initially normal, and they can, if ignored, they become into the decompensated condition. Serial weight measurements, attention to heart rate, weight gain and all. Weight gain not more than 0.6 kg per, these anemias to be treated. Then urinary infection definitely taken care of there. Then detailed malformation scan, definitely to this level 2 sonography is required, and again that fetal growth restriction we take care of. So, if lady even on examination, that if she is coming with acute cases of this congestive cardiac failure, or maybe in the persistently having, so these we reduce the workload on the heart with the bed rest, but the restricted activities which helps in avoiding the tachycardia and improves the renal perfusion. And these bed rest increases the chances of, you all know, thromboembolism and pulmonary embolism. So, these again the question arises, the strict bed rest definitely in the acute phase we require, but otherwise we restrict their work load. Prophylactic heparin is in some cases you have to use, and then the role of diuretics, definitely in the acute phase you have to give the IV, and then followed by it is to be given on, patient should be on the oral maintenance dose. Serial hematocrit, electrolytes and creatinine measurement required, and again these dose of diuretics should be adjusted to as keep hematocrit slightly above the value obtained before the therapy. So, these should be the criteria to adjust your diuretic dose. And then digitalis, which is the drug of choice, we commonly use preparation digoxin. Loading dose is we all know 0.5, maintenance it should be a 0.25, and 0.125 to 0.375 is the range we use these drugs, and this therapeutic serum level we required 1 to 1.5. These are we clinically monitor, we never go with the biochemical examinations. Therapy adjusted according to the patient's clinical response, and then definitely to avoid the arrhythmias and pulse rate we say. Side effect most common is the arrhythmia, and which should be taken care, and these if it develops then discontinue the drug, and then correction of the hypokalemia is to be done. Then vasodilator therapy, which decreases the afterload of lowering the systemic vascular system. Drugs used are the hydralazine and nitroglycerin and nitroprusside. Hydralazine is the relatively safe use, because we have experience of using this drug in severe hypertension also. So, in acute cardiac emergency, nitroglycerin is the vasodilator of the choice. Nitrates reduces both preload and afterload, both it is, and sometimes we require the dopamine and dobutamine in these cases. Pulmonary edema, in this cases we should take care of, there should not be a development of infection. So, you avoid these chorioamnionitis, infection, fluid overload, administration of beta adrenergic drug, pre-eclampsia and eclampsia conditions, pulmonary embolism, and these conditions predisposes the pulmonary edema. So, treatment part should ideally to take place patient into the ICU, and invasive hemodynamic monitoring is required, and correction of the tissue hypoxia and acidosis, and most common form of the pulmonary edema is seen in obstetrics while doing the preterm labor. So, you should avoid the beta adrenergic drugs in these patients, having combination of, they may have chorioamnionitis infection, beta agonist and glucocorticoids, the treatments we used to give, these increases the chances of pulmonary edema. So, this condition is exaggerated again with the multifetal pregnancy. So, again these are the high risk patients. So, in preterm you, if lady develops pulmonary edema, you discontinue these labor inducing drugs, inhibiting drugs, and then again you require the treatment with the furosemide and then oxygen by mask. Pre-eclampsia, we all know that if lady develops, then the early delivery is one of the most important treatment. So, standard care in labor, I'm not touching with all these part of the labor, but still we go that we have to decide where the lady should be delivered normally or go for the cesarean. So, the conditions which increases these means if any of the cardiac condition which increases by the basal members, definitely these are not the patients to deliver manually, means vaginally, these are to be taken for the cesareans, and the spontaneous labor to be waited if there is no any obstetric and non-obstetrical causes indication becomes, these patients should be delivered normally vaginally, and induction should be avoided. If required induction, then the oxytocin and ARM are the choice of method. Prostaglandin should be avoided, and these in labor definitely we have to monitor these patients, and delivery should be in the hospital, and every unit should have these HDU unit. So, we can have this provision to take care of that, and until unless you require an ICU, definitely shift over there. And one important part we all know, that is the cut short, the second stage. So, instrumental delivery is required. In these cases still we need these outlet forceps we are using, and IV fluid should be restricted, it should not be more than 75 ml per hour, and post delivery the early ambulation is required in these patients, because to avoid the thromboembolic phenomena. And some of the non-obstetrical indications in for the cesarean sections, these are the Marfan syndrome, patients on oral anticoagulants, acute and chronic aortic distensions, and these urgent delivery in a patient on the therapeutic oral anticoagulants, this reduces the risk of the intracranial hemorrhage in the fully anticoagulant fetus. So, these are the indications where, and if C-section required, definitely the whole team, the anesthetist should choose their anesthesia accordingly, regional or general. If GA, then suppress the pressure response to laryngoscope, these drugs are to be given, and if regional anesthesia, then titration epidural and spinal is combined. So, for a good outcome we require the close supervision, extra care, well equipped center, definitely the HDU is required in every obstetric unit, ICU definitely in tertiary care centers, and a good team is helpful for taking out the good outcome in these patients. Thank you.